Good afternoon, everybody. This is our weekly town hall for COVID. First off, I wanted to say thank you, Environmental Services. This is your week. Actually, it's your year. We wanted to say thank you for helping us and keeping us in line and taking care of our elevators, our hospital rooms, every single thing. We applaud you and appreciate you highly. I'm Dr. Almina Free. I'm Vice President of Medical Affairs and Chief Medical Officer at Stringfellow and Regional Medical Center. I'm an internist by training, have been here 25 years. I did my training at Cleveland Clinic, and I'm now in administration. I still work as a hospitalist. I am very dedicated to this community, love my patients, love my staff, love my administration, and we're here to give you a bit of an update. So I've gotten information from the Alabama Department of Public Health dashboard, and as you guys have known, our numbers were very high last week. We have come down somewhat, thank goodness, more because we've discharged patients, of course, from our hospital, and unfortunately we've had some deaths, but it's across the state that the numbers are going down intermittently. We won't say intermittently for now. But as of yesterday, from the Alabama Department of Public Health, there are 3,944 COVID-19 new confirmed cases. Every day we get information about how many thousands of confirmed cases there are. It could range from 2,000 up to 4,000, almost up to 5,000. 761 confirmed COVID positive patients are in ICUs across the state. 48% of ICU patients are COVID positive. 558 ventilated confirmed COVID patients have been noted from yesterday. That number always changes because patients' needs for ventilators come and go. 73% of COVID patients in ICU are ventilated. Now, as far as our ICU beds availability across the state, it's -3 as of yesterday. It may change, and I will get this information on a daily basis about 4:30 p.m. from the Alabama Department of Public Health. In the Northeast region, we're at -10%, so it's pretty tough. We're very, very tight for ICU beds and critical care needs. For the 10-day summary inpatient, this is something that has been formulated newly through the Alabama Department of Public Health, information about pregnant patients and pediatric patients. Mind you, some of the hospitals across our state didn't get information in time, but what I've received from Alabama Department of Public Health dashboard yesterday, 25 pregnant COVID inpatients were noted. 2 of those are in ICU, but none were ventilated as of yesterday. Now the numbers have changed and we'll have to get that updated. Pediatric COVID inpatients are 46, with 21 in ICU and 7 vented as of yesterday. At RMC, we have now 69 COVID positive patients in our facility. Last week, we got up to 93 or 96, was that, Dr. McGraty? So 96. At least 89% of those patients are unvaccinated. In our COVID ICU 1, we have 22 patients, but we have 24 ICU patients. 22 ICU beds in COVID 1, but 24 ICU patients, which means of those 22 patients, we have 19 ventilated, and we have 2 other people in the COVID 2 unit that are ventilated. I think we have 22 patients in COVID 1, and then 2 patients that may be ventilated in COVID 2. 90% of those are unvaccinated. We have 33 total vents house-wide. We have an 18-bed ICU unit. Unfortunately, we have to reappropriate nurses in different areas to take care of our ICU patients, which means the nurses that are typically taking care of 2 patients in ICU are tripled. What that means is that they're now taking care of 3 patients. We have to reappropriate ICU nurses from our regular ICU to COVID ICU and utilize that type of personnel. It's very difficult, but this is what we're doing. In our ER, we have 6 patients holding. 1 is an ICU patient, 5 are medical. I was just informed about 5 minutes ago, though, that we think we have 2 beds that we may need to move about, that we can get 2 of the 5 medical patients up. In the past 24 hours, we've had 9 admissions before this morning. For the month of September, we've had 111 admissions. And for year to date, when we started admitting patients, we've had 1,465. As of yesterday, there were 3 deaths in the 24-hour period. For September, we've had 30 deaths at regional, and for the year, 282. We have 2 patients that are COVID and flu positive. One of those patients is an ICU vented patient. At Stringfellow, I touched on this, we have 1 unit that's appropriated for COVID. It was the previous detox unit. That floor can hold 12 patients, I'm sorry, but it has only 8 because of some mechanical issues with the other beds. We do have 1 patient in Stringfellow's ICU that is a COVID patient that is on a ventilator. They have had 2 deaths occur this week since the start of their COVID unit. The treatment, of course, I want to talk briefly about the monoclonal antibody. So casirivimab and imdevimab are the combination monoclonal treatments that we've been giving through the 10th Street School recently. We were giving that medication at the Tyler Center, but found that we needed a bigger venue, and we were graciously granted the ability to use the 10th Street School. So on last Wednesday, last Friday, this Monday, we were able to give 202 monoclonal antibody injections. Unfortunately, the Health and Human Services, along with the Alabama Department of Public Health, are now appropriating the monoclonal antibody treatments, and we have none at this present time. We're working very diligently with the state and the United States, the government, to get more monoclonal antibody in this area, because what we found was that this medication helps mild to moderate COVID positive patients with treatment and keep them from getting extremely ill, hopefully keep them from being admitted, and if they are admitted, they're not so sick. Some of them do, of course, become critical and have to be ventilated, but that was a way for us to treat people before we could get them into the hospital and before they would progress to an illness or even death. Bamlanivimab, etesivimab were available in the past, but we found through research and trial and error that this medication was helpful for the wild type, but for the variant that's present now, it's not being used in this area. So Trovimab is a infusion medication. It's a monoclonal antibody that is available but has to be bought, and it's greater than $2,000 a pop. For our vaccines, we still have Moderna and Pfizer in this area, and I think I'll leave that for Candy to talk about. I just wanted to end by saying the CDC revealed that individuals that are not vaccinated were 4.5 times more likely than fully vaccinated to get infected. They're over 10 times more likely to be hospitalized and 11 times more likely to die. So please help us. Wash your hands, watch your distance, wear your masks, vaccinate, stay safe, take care of your loved ones, and take care of yourself. Thank you.
Okay, good afternoon, everybody. Dr. Free covered a good bit about what I was going to tell you today, so I will add some extra little tidbits in there. I'm Candy Williams. I am bringing you the hospital infection control / vaccination report. Vaccinations continue to be the #1 way for you to protect yourself from COVID. We've known this. This is not a surprise. Currently, 90% of our patients are unvaccinated. If you at this point are deciding that it's time to get the vaccine finally, we are so very proud of you. We are offering the Moderna vaccine on Thursdays from 8 to 10 at the Tyler Center on the 4th floor, RMC Wellness. RMC Wellness, and the Pfizer vaccine on Fridays from 8 to 10 at the Tyler Center, 4th floor, RMC Wellness. So, typically after that conversation also comes the questions about boosters and third doses. Third doses and boosters are two very different things. Third doses are for those patients that are severely immunocompromised. You need to think your cancer patients, your stem cell transplants, your HIV patients, patients that are severely immunocompromised qualify for a third dose of the vaccine 30 days after their second dose. That is not the mass majority of us, okay? They have said that boosters are due 8 months after your second dose. So we're just now getting around to the point where the majority of our population is approaching that deadline. And the first group of that population will, of course, be healthcare workers, because that's where we started vaccinations last time. So Dr. Magalia talks about a tiered approach. That's the same thing. How we rolled them out the first time will be similar to how boosters are rolled out the second time, okay? So we will provide booster vaccines to our employees through the hospital. At this time, RMC is not planning to host large mass vaccination booster sites. I know that there has been communication and discussions in the community about how we can provide those, but I will tell you that there are numerous providers in our community who offer the vaccine. If you go to vaccines.gov, that's vaccines with an S, you can locate a provider in your area that is close to you that provides the vaccine at a date and time that is good for your schedule. So you're not tied to a specific date and time at a clinic. You go wherever you want to go, to your pharmacy, to your primary care provider, and you get that vaccine. They will let you know if you qualify for a booster dose based on their recommendations, okay? So you know when your second dose was, you do not need to get a booster until it's time, okay? We want to make sure that we roll these out as appropriately as possible. The next conversation will be about testing. So there is an increased need, of course, in the community for testing, because now everybody is getting sick, and so hopefully we're starting to get on the other side of this, but I still get lots of texts and calls about testing on a daily basis. We have lots of providers who provide testing, but there are a few drive up or non-provider based locations in the community that you do not have to see a provider. Those are the Calhoun County Health Department. You call, make an appointment with them. They have certain dates and times that they provide testing at their facility. Also, RMC Mediplex, which is associated with the hospital, has a drive-through site. If you will call 256-235-5600, leave a message. They will return your call and schedule you an appointment through our drive-through facility. That is open during the week. I believe it's 8 to 4 on that. There's also a new site that has been established through a partnership with ADPH that will be located at our Medical Arts building where testing first began way back when. The address is 230 East 10th Street. It's located behind the parking deck to the hospital, between the parking deck and the Alabama Power Building. This will begin as early as this Saturday and run for 7 days a week, and their hours are 10 to 6. They do strongly prefer that you have an appointment. We will post the link on our website so that you can sign in and get an appointment for that. If you're not able to get an appointment, they will accept drive up style appointments based on availability of testing and appointment slots that day. So prefer to get an appointment. Please don't just show up if you can help it at all, okay? So let's talk about antibodies. Dr. Free touched on the fact that as recently as yesterday, we were notified that we will no longer be receiving our normal shipments of the monoclonal antibodies. The government has decided to allocate those, and the health department will run point on that. As soon as they receive the medications, they will allocate based on need to the communities throughout the state where they feel like it needs to go best. And so we have put our request out there. We have indicated that we are out of the monoclonal antibodies, and we hope to receive those as soon as they are allotted to us. So what does that mean for you? If you were someone that was on the schedule for today, you would have gotten a phone call yesterday to let you know that the appointment was canceled. We are operating on a day-by-day basis. when we get the medication, we will be ready to roll to administer that medication as soon as possible. But again, it's a day-by-day basis. So we will look at Friday appointments tomorrow afternoon and let you know if we have received that medication or not. If you are a patient that was discharged from our emergency department and we're told to go to the 10th Street Elementary location today, you will be met with a sign that says, of course, the site has been closed because we do not have that medication. Please come back to the emergency department and we will take care of you and get your orders put in line for that medication when it becomes available. But you will need to come back and bring your order with you. You will not be seen as a patient, but we will make sure that we get you in line to receive that medication as soon as it becomes available. Thank you.
Good afternoon, everybody. As you all are aware of it, I'm Dr. Patel. I'm the pulmonary critical care and sleep medicine, and I introduced myself last time. I'm not going to do the same thing again, but basically I'm extending my update based on what Dr. Free just told us about the ICU. First of all, I would like to thank the environmental services, and I also would like to thank the team, the whole team which is involved in taking care of the patients over here in the hospital. You start from administration all the way to the environmental services, including doctors, nursing, everybody. So I will not forget anybody but the whole team, because what we have seen in the last 2 weeks is very unusual, never seen like this before, and everybody is standing by together, nurses, everybody is working overtime to help out as much as possible. So just want the whole thank you to the whole team. Talking about ICU patients, as expected, due to that many number of admissions, people are getting the complications of hypoxemic respiratory failure due to COVID, and basically there's a stepwise approach between myself, Dr. Magadia, and all our 4 pulmonary critical care and nurse practitioners, how we manage those patients. So initially when they come to emergency room, we just assess them. If they are mild hypoxemic, we put them on dexamethasone and oxygen and observe them. And if they need to be have an addition of a remdesivir, we do that. If they progress towards high flow nasal cannula, then we try to add berosentumab, which is JAK inhibitor, as an anti-inflammatory to prevent the cytokine surge. And then if they go on the ventilator, then we put them on tocilizumab. This is all done in a systematic way. Nobody misses it between myself and the team, Dr. Magadi and everybody. We look at everybody. I just want the community to know that even though we are busy, things have been taken care of behind the doors as they're supposed to. We look at the protocols. I myself look at the protocol, and Dr. Stevens and everybody, Dr. Schubert and Dr. Ferguson, Dr. Magadia, look at the protocols for the other hospitals. We talk to other hospitals. I actually looked at the protocol earlier this morning from Regimen Hospital in Boston, and we are following the exact protocol we are following over here, but they are following over there for the treatment. So that's basically the treatment. Basically, we just use the steroids and the medicines accordingly. Now, what I'm trying to tell you is what we are seeing is complications. These are the complications we see on the patients on the ventilator who are doing fine at one moment, and then next thing you know, they end up on the ventilator within half an hour, 45 minutes. And it's very hard to predict who is going to be doing that. So we keep a very close observation. Nurses, staff, respiratory therapists, everybody's trained. As soon as they find the patients have taken for worse, immediately the team goes there and takes the patient to ICU and intubate them. And then we put them on the ventilator settings, as we have talked about before. We have the ventilator management strategies planned out, and all the respiratory therapists know what to do about it. But what we are seeing, and this is my observation, is people are getting what is called as a pneumomediastinum, which is a leak in the air from the lung and goes around the structures with the blood vessels and the heart. It's called as pneumomediastinum. And that is, unfortunately, an unusual complication, generally speaking, in normal patients who have ARDS, but this is more common so in COVID patients. This is because of the thinning of the lung walls, piercing the air outside the lungs through the bronchiovascular bundle and going to the mediastinum. And that air comes out and then comes out to the neck and to the eyelids and everything, and people have really puffy skin after that. And that is, unfortunately, one of the indicators for poor prognosis, in my opinion. Now, the data will tell us down the road, but what we are seeing, that very few people who have that complication survive. So that is one thing which we are seeing. Other thing is people who come with Yesterday a patient died with a massive MI after having a COVID infection on the ventilator. So people do develop complications from having COVID-19. Stress, age, all related factors will cause them to have massive MI. People also come with a massive PEs, even though they're not documented, their right side fails, and then one of the patients in the current, and we have to give a TPA. So we are giving the TPA as a part of salvage therapy in patients who are hemodynamically unstable and who have significant RV failure. So those are the complications we are seeing, and these are very problematic complications, and most of the people don't survive when this complication occurs. So basically, that's the ICU complication related problems. Now, I want to make sure that just a couple words here about, I have 5 patients with bad COPD who had been vaccinated fully, and they were good citizens. They listened to us what we told them to do, and they did get COVID, and they both went home within 3 days, or 4 of them. So that indirectly tells me that even despite of bad comorbidities and patients have taken COVID vaccine, they survived, even though got 6 months later they got COVID. So basically, that is another testament that people should be vaccinated to prevent the severity of the disease and eventually the death. And last thing is, do not forget about the non-COVID patients. We have a problem right now. We are overwhelmed with the COVID, and I'm asking the primary care docs and community docs in general, please listen to them, because there are no rooms in the ER, and so just bring them in the office. Try to do the best you can, help them out for the non-COVID patients, because we are seeing MIs, we are seeing COPD exacerbations, we are seeing a pneumonia. All those things are happening in non-COVID patients. So just watch out for them and help them out. Thank you.
Good afternoon, Dr. Magadi. I'm the infectious disease specialist. I'm the chairman of infection control and prevention, and I'm chairman of antimicrobial stewardship as well. I'm one of the physicians involved in the COVID ward. One of the things that we noted when we do our HNP, or talking to patients who came in about why did you not get vaccinated? Some of them said, I'm scared of it, or I'm just waiting. But time and time again, we would hear people, oh, it's not really protective against this new strain called Delta strain. So pre-Delta, we know that the vaccine, Pfizer, Moderna, J&J, they're protective against the wild type or original strain. We also, based on historical data, that it should be protective against the subsequent strains. But now we have specific data that came out 5 days ago. There are 3 papers that came out on the 10th. One paper I'm holding. It's from MMWR, for the primary care guys. It's a good read. It's a paper from MMWR about the real-time data on COVID cases in 13 states. There's another data that came out of LA, same kind of findings. There's another paper that came out also right around, the 3 papers came out right around the same time, from published at MMWR. One is from LA, one is from New York, and the other one is from 13 states, including Alabama. So I read 2 of them. The one from New York I have not read yet, but the one from LA, it was a quick, easy read. But the one from the 13 states, including Alabama, kind of piqued my interest because Alabama was included in the numbers. So anyway, so let me just break down the data there. Pre-Delta, we know that the vaccine works against a variant strain. But this paper specifically says that the vaccines, Pfizer, Moderna, J&J, are protective against the Delta strain because they have specific numbers. So this paper that I've been holding across 13 states, Alabama, Arizona, Colorado, New Mexico, New Jersey, California, and Colorado, they had 569 cases. 91% of those cases were unvaccinated. 92% of the one who got hospitalized were unvaccinated. 91% of who died unvaccinated. So about more than 90% of people who have COVID didn't do well, got hospitalized, eventually, unfortunately, died, were unvaccinated. And this study was collated April all the way to, I think, about 3 weeks ago. So this is Delta time. As you know, Delta actually became prevalent here sometime in July. I think they discovered that here in the States in the end of June. We reported our first Delta case late part of July. Currently, the predominant strain, circulating strain here in the States is Delta. So the reasoning that I'm not gonna get vaccinated because it's not gonna be protective against the other strains as well, completely false. So just to summarize, I kind of summarize this for you guys. So these 3 papers show this. So after Delta, those vaccinated, you are protected against infection 5 times, hospitalization more than 10 times, and deaths more than 10 times. So that really is a driving, one of the reasons why we seriously recommend that you get vaccinated, especially with the Delta. So forget about the papers and stuff. I kind of just summarized that for you. So now a question about how are you all counting a fully vaccinated patient? So by technical definition, fully vaccinated is somebody who has had vaccination 2 weeks after the second dose of either Pfizer or Moderna, or the 2 weeks after the single dose of J&J. So if you're not within that period, or within that period, not outside that period, you are called partially vaccinated, and we have that data as well. Second question is, are there any patients in your hospital being admitted due to vaccination complications, or are they being included in the COVID numbers? No. We had one case, I think sometime in March or April, a healthcare worker who had some kind of anaphylactic type reaction, tongue swell up with Moderna. She had to be sent to the ER, gave some epinephrine, gave some steroids, but she did not need to be hospitalized. As far as I know, we have not had anybody admitted to the hospital because of side effects related to the vaccine. And we're not gonna lie, there's some side effects or adverse reactions related to the vaccine. Injection site reaction, fevers, bone aches, muscle aches, 1 or 2 days, sometimes 3 days, but they're not bad enough or severe enough to warrant hospitalization. So far in the United States, there are about 156 million doses given, and you don't hear a hospital opening up a specific ward for COVID adverse reaction. All the wards being open right now is for COVID itself, not the COVID vaccine complication. So you might have some adverse reaction, but not severe enough to warrant hospitalization. Okay. How many blood clots are you seeing with vaccinated patients and then positive COVID patients? So one of the pathophysiology of COVID is either micro or macrovascular thrombosis. Micro meaning small, macro big blood clots, either DVTs or deep vein thrombosis in the legs, or pulmonary thromboembolism or PE. Sometimes we don't really see them. We might be able to see them on chest X-ray or CT, little tiny thrombosis. So that's one of the reasons why they don't make it, because of those thrombosis. So everybody, and Dr. Patel will concur to this, everybody who has COVID, regardless of their D-dimer, they have what we call a DVT prophylaxis regimen, either heparin or low-molecular weight heparin, or the newer ones called NOACs, Eliquis, and those type of anticoagulants. If we do confirm that they have a known DVT or PE, we give them full dose anticoagulation. So those, which brings me to the main treatment regimen that we give in-house. So the 3 main things that have been proven time and time again to be kind of beneficial in patients with COVID are 3 things. Oxygen, because they come in, with hypoxemia, especially if they're coming in below 94%. Number two is steroids. We give them dexamethasone based on the coverage trial from the UK. And number three is anticoagulation because they have micro or microvascular thrombosis. The rest, the vitamin D, the famotidine, which is a H2 blocker, remdesivir, even monoclonal antibodies like tocilizumab, they are good adjuncts, but the three main ones that have been shown to affect survival and decrease death are oxygen, steroids or dexamethasone, and anticoagulation. That's it.
One question
Questions?
from Bill Wilson. He asked, what's the average stay at RMC of COVID patient?
Hi, Bill. So typically, when you have to kind of categorize patients between severe to critical ill. We don't hospitalize mild to moderate patients. They usually get taken care of maybe in the ER or local urgent care or their primary care. So if you break down the severe against the critical ill patients, so the severe ones, they're the ones who might be needing supplemental O2 with nasal cannula or maybe high flow O2. They typically stay with us about 5 to 7 days, within a week. The ones needing more oxygen, you're talking about non-invasive mechanical ventilation or BiPAP, and eventually intubation. They're staying with us longer, talking about 2 weeks, sometimes 3 weeks, sometimes a month. So it's kind of hard to tease out, so you have to break it down to severe to critical ill. So, but on average, about a week for severe and maybe 2 weeks or longer. Is that correct, Dr. Patel? Yeah, 2 weeks or longer for critical ill, those intubations, maybe longer if you get put on the vent.
Question from Becky Turner. Should those who receive the Johnson & Johnson vaccine get a Pfizer booster?
Hi, Becky. So the current recommendation from FDA about the booster or the third dose that Candy alluded to is related to both Pfizer and Moderna. So if you got Pfizer or Moderna and you're within that 8-month period, or if you're immunocompromised and you have gotten it 4 weeks earlier, you are eligible to get either the Pfizer or Moderna. We do not have, or FDA does not have recommendation for J&J yet. So I think you're alluding to a crossover. There's a crossover study by NIH and the UK, and they seem to think that it's safe. It's also effective, but it's not recommended yet because it's just a clinical trial that involves small, I think about 250, 300 patients. But right now, we do not have recommendations for J&J for the booster. We do have recommendations for Pfizer and Moderna.
Question from Deborah. Is the virus stable on inanimate objects and surfaces? If so, how long?
So the early on in the pandemic, we were freaking out with what we call fomites. Fomites are inanimate objects wherein the virus might land. So a lot of people were washing and cleaning and wiping everything else. As a matter of fact, people were coming into the hospital, coming into the hospital with civilian clothes, and then they change to scrubs, and then they go home, take out their scrubs and go home with the regular clothes. I did that also back then. I was wearing scrubs, and then this might be TMI or too much information for you guys, but I was actually undressing in my garage and just darting out in my house to go straight to the bathroom and shower. I'm not really doing that now based on fomite studies that says that the virus is actually aerosolized, so they float in the air, and when you inhale it, that is when you get it. Not so much when they land on fomites or inanimate objects. So we still recommend that you wash your hands. We still recommend that you wipe all those things, but not so much because a lot of things have changed. A lot studies have shown that they don't really last that long. Technically speaking, they are protein. They're not really viable outside the host, so they need us. Or any mammals for whatever reason, so they don't really survive that long in inanimate objects, including chairs or clothes.
few more questions. One from Marissa Cobb. She asked, have you seen a lot of cases where a person is having long-term lung issues such as oxygen dependent once they've had COVID?
Marisa, that's a Patel question. Dr. Patel.
Yes.
Sorry.
And Marissa, yes, so basically there are subset of patients, not that many, but there are subset of patients who develop a severe pneumonia and they either survive the ventilator or they go on a high flow nasal cannula for at least 4 to 6 weeks. Those patients come in for follow-up in the office and most of them has gone back to normal according to our experience for a year ago now. But there are a subset of people, very few, I would say more than 5%, less than 5% of people, of those people who have severe pneumonia will end up with residual pulmonary scar tissues in the lungs and eventually require to oxygen for at least 6 months to a year. I have not a single person in my practice which had not come off the oxygen after 6 to 9 months. Any other question?
Are you? Oh.
Alright, I just wanted to wrap it up and recap what we've covered today. First, thanks to all of our environmental services staff on your week. Thank you so much for all you do. Second, thank you to Stringfellow, who've now opened a COVID unit. And thirdly, thank you to our team who has been treating and testing and providing vaccines. If you need tests, we are going to have a drive-through test site in the Medical Arts parking lot. It is located at 230 Layton Street. It's across from the physician office building. We're going to share information so you can get pre-registration details and sign up online. If you need a vaccine, we have them on Thursdays and Fridays at the Tyler Center, and we also have them at the Oxford Metaplex. Please call 256-235-5600 for testing and vaccine information. And that's all for this week. If we didn't cover your question, we will try to get to them next week or answer in the comments. Thanks so much.